At Philips Foundation, we believe that technological innovation and collaboration can help solve some of the world's most profound challenges in providing access to healthcare. Today, nearly half of the world's population lacks access to essential health services. 100 million people fall into poverty each year due to unavoidable healthcare costs. By working together with non-governmental organizations, local entrepreneurs, governments, and healthcare providers, at Philips Foundation, we developed a deep understanding of local healthcare challenges. We are committed to improving access to healthcare by leveraging Philips' expertise and deploying technologically enabled solutions, empowering local health workers and strengthening community and primary care, and by fostering financially sustainable and scalable healthcare delivery models. We contribute to good health for all by addressing the rise of non-communicable diseases, such as cancer, cardiovascular, and respiratory diseases, improving mother and child care by making quality health care more accessible to mothers and children, and accelerating access to acute and emergency care through timely medical support in emergency situations. At Philips Foundation, we challenge the world around us to provide access to quality healthcare for 100 million people a year in underserved communities by 2030. By working with like-minded partners, we can promote health and well-being for all.
Hello, everyone, and welcome to today's webinar. My name is Margot Kooijmans, Director of the Philips Foundation, and today's webinar is the 6th webinar in the Philips Foundation Changemaker series, in which we aim to share the lessons that we've learned in our work and share the best practices in our search for sustainable models to improve access to quality healthcare for disadvantaged populations. Our mission as Philips Foundation is to provide healthcare services to underserved communities, also by deploying Philips expertise in healthcare technology, aiming to make a lasting change for many people. Our target is to improve access to quality healthcare to 100 million people in underserved communities a year by 2030. Why do we do this? We know that more than half of the people of the earth still don't have full coverage of essential health services, and almost 100 million people fall into extreme poverty due to the costs of a sudden healthcare issue which they cannot afford annually. Therefore, prevention and early detection of a condition can help make healthcare affordable. It can help avoid severe conditions and even save lives. Especially large populations that lack adequate access to quality healthcare are in Africa, Asia Pacific, and Latin America. We believe that technological innovation can drive change in healthcare systems underserved communities across the globe. Today, we want to share how our programs with handheld ultrasound, telehealth, and creating the right ecosystems around it can strengthen community and primary healthcare. Two of our respected partners will explain how they deploy these enablers for better healthcare in different geographies. I hope it will inspire you. Thank you, Dr. Modoni, for moderating this webinar, and over to you.
Thank you very much, Margot, and good day, everyone. Thank you so much for taking the time to join us for this webinar. My name is Dr. Muthoni Ntonjira. I lead the Philips business in East Africa, based out of Nairobi, Kenya, and I'm truly honored to be moderating this particular webinar. According to a recent report by United Nations, maternal mortality remains a major concern, with one woman dying every 2 minutes due to complications related to pregnancy or childbirth. The majority of these deaths occur in the most underserved parts of the world. Improving access to quality maternal and child care in underserved communities can help reduce child and maternal mortality rates and improve the livelihoods of these local communities. Moving on, the WHO recommends that an ultrasound scan before 24 weeks of pregnancy to estimate gestational age, improve detection of fetal anomalies and multiple pregnancies, reduce induction of labor for post-term pregnancy, and improve women's pregnancy experience. However, unfortunately, universal access to obstetric ultrasounds during the prenatal care remains elusive in many underserved settings, despite this recommendation. However, but there's still light at the end of this tunnel. Technological innovations in ultrasound and empowerment of healthcare workers to perform high-quality ultrasound during antenatal care can help overcome some of these access barriers. I'm truly honored to have this discussion in this session where we will delve into this particular topic, which will be presenting insights gathered by partner organizations of the Philips Foundation. It is my pleasure now to introduce our first speaker, who will be leading these two sessions. We have the first sessions where we have lessons from the Aga Khan University. The second sessions will be on lessons from SAS Brazil. And the third part of this session will be a Q&A segment where we'll address all the questions that have been posted by the audience and also get into any areas that require further clarity based on the presentations that will be done by the panel. Please feel free to put in your questions in the course of this discussion so that we are able to address them at the end of this session during the Q&A segment. So to start off, Prof. Marlin is not a new face for us. She's a very well-recognized global leader in women, child, and adolescent health. She brings academic, technical, political, governance, management, and leadership skills to the table, as well as diplomacy, advocacy, fundraising, training, and clinical expertise. Currently, Prof. Marlin is the chair of the Department of Obstetrics and Gynecology at the Aga Khan University Hospital, and she's also the director of the Center of Excellence in Women and Child Health at the Aga Khan University. Prof. Marlin, over to you.
Thank you so much, Dr. Mutoni. Nice seeing you, and thank you to the organizers of this webinar, the Philips Foundation and colleagues, for inviting me today, because indeed, as was already said by Dr. Mutoni, by Margot, there is still a lot to be done in this area. And maternal mortality, despite many efforts in the MDG period, is still a problem. Still today, one woman every 2 minutes, 800 women every day are still dying of pregnancy-related causes. Now, prior to coming to Nairobi and the Aga Khan University, I was indeed the director of WHO Department Women's Health and Research in Geneva. And we worked with my department very closely to see what is needed actually to make a difference, not only in maternal mortality, but also in perinatal outcome. Because, you know, we still have too many stillbirths, too many preterm babies that are born without, you know, the prevention or without the measures that the care that they could have had, too many lives lost. And we really have to think kind of all together. The good thing about these sustainable development goals is that indeed it is everyone, the UN, the governments, public sector, private sector, advocacy groups, community groups, academia, everyone joining to address some of the problems. And one of the problems that was identified a long time ago was indeed the fact that women in this part of the world, in very many communities, they don't know their gestational age. That's really a big problem, because if you have a woman in labor, you see her for the first time, I'm a gynecologist by training, You see her for the first time and you don't know whether she's like 28 weeks, 30, 32, or more. It makes a big difference in referral and in management. So we worked with my team, and it takes a long time at WHO to have a good, to come up with a kind of global guideline, but we did. And one of the WHO recommendations in the context of optimizing antenatal care was indeed to provide access to ultrasound, at least one, in the antenatal, in the prenatal period, and if possible before 20, the earlier the better, but let's say before 20 to 24 weeks of gestation, because then we are still able to measure the fetus and to have a good estimation of the gestational age, to refer if we have problems, also to see whether they are twins, and a number of other things that we can detect with ultrasound. So that should be a kind of a basic requirement. Unfortunately, we are not there yet. And next slide. Yeah, so there are many problems. I don't have time to elucidate all of them. But one of the solutions is indeed, it's easier to set from the mountains in Geneva. We have to make ultrasound available antenatally to everyone. How do we do that? How do we do that in a country like Kenya, where I work? So we, together with Philips, with the Philips Foundation, Aga Khan University, the Kilifi County government, we embarked on a project, and we said, well, what do we need? We need machines, we need equipment. So we worked with the Lumify, portable ultrasounds that are very easy to handle. Number two, you need people who can do it, and midwives, the nurses. There is a whole discussion about who should be allowed to do it, but I'm not embarking there, that's for later maybe. So we need equipment, we need people who are trained, and we need the healthcare sector to come in and to really allow more personnel to be trained, but also more time to do the ultrasounds. So we embarked on a solution. And the study is a bit complex because we had 4 arms with ultrasound, no ultrasound, ultrasound plus MOM, that is a technique to improve communication and with the community healthcare providers, etc. But you know, we embarked on this and we trained, and Dr. Needy will tell you more about that. We also followed, we did monitoring, we did baseline, a midline, an end line, continuous monitoring. Now we know that with this relative limited budget, we were not going to measure really hard indicators like stillbirth and maternal mortality, etc., and preterm birth, but proxy indicators are the moment that the woman comes for her first antenatal visit. Usually women come very late, and then it's difficult to do a number of interventions. So why would they come early? What do we offer them? We have seen that by introducing this, as they call it here, the gadget, by introducing ultrasound. Initially, we had to kind of talk about what it is, acceptability, etc. But it was very well accepted by the women. Then we checked, are the women coming earlier for their first antenatal visit? Because that will give them more time. And indeed, as you can see on the graph, gradually we see that women do come earlier for their first visit, which allows us to give more antenatal care, to also have a birth plan, prepare the delivery, the childbirth, and to have more involvement of the partners and the families who support the women. So the Mimba Yangu, that's the name of the project. It means my pregnancy. The Mimba Yangu really has shown that it is feasible to do it. We can train the staff. Women like it. So we should continue. This deserves scaling up and monitoring on a larger scale to really measure how many lives we save. Now we can do it with modeling, and we are convinced that we have a really positive impact on pregnancy outcome. And then the next slide is actually what the lessons learned. Well, as I said already, is it feasible? Yes, takes time. but it's feasible to introduce ultrasound even in a rural area and to make it part of the routine antenatal care provision. Women appreciate it, family, partners, the healthcare providers, everyone loves it. However, it is also important to work within the national and the county frameworks and the regulatory arrangements. For example, do we have currently already national guidelines? We are working on that. A regulatory framework, who is allowed to do ultrasound? Of course, the nurses, the midwives, but also the radiologists, the radiographers. So we should have kind of a national guideline on this. Co-creation and collaboration with county governments is key, because initially, many projects, you see a project is ongoing 4 years, the project stops, leaves, writes a report, the equipment is there, and after 2 years, it's not used anymore. So we worked with the county government, really coming to a kind of an agreement that they would allow staff, and also that the county government has a budget for maintenance and upscaling. Training, and that's what my colleague Dr. Nidhi will tell you, training takes time, and it will take a lot of time if we want to train the huge workforce of the healthcare providers, the midwives, the nurses. So what should be done in the future is that ultrasound, obstetrical ultrasound, is part of the pre-service training of the nurses, midwives, everyone who is in the healthcare sector. Applicability, relevance, acceptance, cost effectiveness, and implications on health service planning and provision at the primary care level has to be scaled in the Kenya context. Muthoni, over to you.
Thank you so much, Prof. Malin. And just listening to you, I can actually fully relate with what you're saying, because I had the privilege of actually seeing the impressive work done by yourself and Dr. Nidhi at a healthcare facility in Kilifi. And it was just so heartwarming to see a midwife do such an elaborate ultrasound scanning for a patient. And before I preempt Dr. Nidhi's presentation, I have the honor of introducing her. Dr. Nidhi Lika is a full-time faculty and consultant radiologist. She heads the ultrasound department at the Aga Khan University Hospital. She's trained in fetal imaging from the Fetal Medicine Foundation in the UK and the Gynecological Academy of India. She's currently pursuing a diploma in fetal imaging with the University of Barcelona. She's also serving as a treasurer for the Kenya Society of Ultrasound Committee and she's a committee member of the World Federation of Ultrasound. So Dr. Nidhi, over to you, and really looking forward to hear more on this particular project.
Thank you so much, Dr. Muthoni, for that very nice introduction. And thank you to the Philips Foundation for having us here so that we can share our experiences and the work that we did with this amazing project called Mimba Yangu, My Pregnancy, already introduced by Prof. Malin. So I'm just going to dive into what the role of the radiologist was in the bounds of this project and in the bounds of the study, which was developing a training curriculum for ultrasound for the midwives who had been selected for the project. And we faced a number of challenges when we started with the development of the training curriculum, because we had a sudden lockdown that came in and COVID restrictions. So we adopted a hybrid method for the development of this program. The foundation for the curriculum was based on the guidelines that have been developed by ISWAG and the recommendations that come from them on basic ultrasound scans to be performed at 24 weeks. We created a checklist for all the things that we wanted to teach our midwives. And before we were able to implement this curriculum that we developed, it was very important for us to train trainers who could go into the field. And we're very fortunate to be a part of a university hospital where we have access to resident power. So we had resident doctors in obstetrics and gynecology who we trained for a minimum of 6 weeks to be able to go into the field and teach. There are 3 essential components that define a training process. 1 is having theoretical training, 2 is having hands-on training, And 3 is, of course, having examinations, which I personally feel is the best part of any training program. Maybe it's the teacher in me. So we had theory training that was done in 2 parts. There was Zoom training and there was in-person training provided, thankfully, by the support that we faced from the county. So we had a local obs and gynae doctor who was present in the field at the site of training. And we had, like I said, our resident doctors who were able to go into the field as well. So we provided theory training via Zoom and in person. Hands-on training for these midwives was provided at the facility where they were present for the classes, and exams for which we adopted the Phillips rubric to our specific set. We were also able to provide support after the training during the implementation phase using React and using on-site support with our trainers. Moving on to the actual implementation of the project. Basically, what happens in any context of a clinical scenario is you have a patient who comes into the facility for a scan. The midwife talks to the patient, performs a scan, recruits the patient for this study, and then this data is transferred to us in 2 ways. A report is given to the patient by the midwife, a handwritten report, which is photographed and uploaded through Adobe to a cloud storage server, and that comes to our IT specialist. He then downloads the report and uploads it onto the Aga Khan University's PACS network. The scans that are being done on the device, the images of the scan themselves directly also get uploaded to the PACS network, and then these are fixed up together. So we had access to more than 3,000 scans over a period of about a year and a half, which we analyzed. And to analyze these, we developed a checklist system where we assigned a score to each and every part of the scan that we had taught our midwives to do. When we come to the lessons that we learned, there's a lot. Thank you. So there's a lot to understand when it comes to verification of ultrasound, and there are so many aspects to it. One is quality and making sure that the quality of the images that we're acquiring is good, or it's diagnostic for us to be able to provide a good or a standard report. And 2 is to make sure that nothing is getting missed. So we have novice users who are in the field, we're giving them training. It's very important that we're able to pick up whether they're missing something, and we're able to give back to them if they are scanning patients, and that the patient themselves should be able to get something back. So what we realized when we were verifying these exams and we were assigning scores to each of the criteria in this, we were able to see that by month 7, or more than 80% of the scans had an acceptable score, which we had defined as about 85%. And regular verification of these scans and feedback that we were able to provide also showed us areas where midwives were lacking. We were able to give back to them, and in turn, they were able to give back to their patients. I think it's very important to touch on the fact that there is such a big need to have local resources to support the performance of the scans, to supervise the verification of the scans, and then to have further training and management. And we're very happy to be able to show with evidence that having ultrasound really benefited the patients from coming in. There were a lot of interesting cases that were picked up, a lot of cases of multiple pregnancy, including one which was very highlighted, which is a case of triplets, where a patient came in only because she knew that she was having an ultrasound and that facility was available in her field. So overall, I think it's been an amazing project, and we were able to show that ultrasound in itself adds so much, and having these handheld ultrasound devices in the field can really bring technology closer to the people who don't routinely have access to it. And I think that we can, as a community, benefit so much. But like Prof. Marlene said, work in progress, and we still have a lot more that we can achieve. Thank you to Phillips, and back to you, Dr. Muthoni.
Thank you so much, Dr. Nithi. It was really a pleasure listening to you and Prof. Marlin, and also just recounting what we had actually seen being done in Kilifi County. And now moving out of Africa and moving to South America, and it gives me great pleasure to introduce Sabine Bolonini. My apologies if I mispronounce. She's a Chief Operations Officer at SAS Brazil. Sabine is specialized in human and leadership development, training executives in multinational companies. Sabine has always believed in the importance of leadership in social challenges, and in 2013, she co-founded SAS Brazil. This organization has impacted over 300,000 people in the mission of providing access to specialized health. SAS Brazil has also received national and international awards and is currently a part of the Schwab Foundation, one of the most important social entrepreneurship networks in the world. Sabine, thank you so much for joining us and really looking forward to hear what you have to discuss on SAS Brazil. Thank you.
Hello, thank you, Anton. It's a pleasure to be here. Really nice listening to this amazing experiences. Learned a lot already from Dr. Marlene and Nikki. I really believe that this opportunities of sharing our knowledges and experiences is a key factor. I'm currently in Harvard, at Harvard campus. We're taking a course in leadership and systems change. And it was interesting looking back at these slides and seeing how I would actually approach this talk differently if I had the chance. So I'll try to make both and take takeaways from the course. So before I start talking, I'd like to show a video that gives a little bit more of energy and life to what SAS Brazil has been doing, and then we'll move on into our discussion here and the case we've done with Philips Foundation and the use of tele-ultrasound in Brazil. So hope you enjoy the video.
Come and get to know SAS Brazil's ADU up close. SAS Brazil's Advanced Telemedicine Unit is an extended version of the telemedicine booth. Conducted by health professionals, it offers equipment that allows physical examinations to be carried out under the supervision and support of remote specialist physicians. Teleultrasonography is one of those exams, performed at a distance by a doctor assisted by a nurse who accompanies the pregnant woman in person. 3 screens are used to make the moment more welcoming for the mother and functional for the obstetrician-gynecologist. A camera films the room where the nurse and the patient are while taking the exam. Another screen films the doctor, and the last screen shows the ultrasound images so that the specialist can follow the exam in real time. At the end of the procedure, the professional sends the report, and the pregnant woman leaves with her printed exam. The democratization of access to technology in health is part of the operating model of SAS Group, which uses innovations of the health tech SAS Smart to transform access to health in our country with SAS Brazil.
Thank you for the video. I want to move on, bring a little context of how is health access currently in Brazil. So we are a large country. We have an amazing public health system. We have over 5,000 cities in Brazil. And the biggest challenge in health currently is that access to health is majorly dependent on where you live, right? So it's more like a distribution challenge than essentially that there's not doctors that enough. There are the challenges that 86% of doctors live in 6% of the cities, which usually are the largest cities. Without innovation going on, we still are struggling with mortality ratio between pregnant women and other basic health indicators. So this is really our mission now. How do we make sure that amazing innovations like the tele-ultrasound get to the people who need it the most? And this brings for us 3 key components that we believe are how we could make it happen. First of all, it's the distribution of health. How do we make sure that the specialist or the radiologist or gynecologist or pediatrician that currently live in the bigger cities, how can they reach the smaller cities? This will only happen through digitization. That is the second D that we have. So the only way, it's impossible for a doctor to be in every city or every community. So the way to do that is, as this other amazing words, through a screen, right? You have the same gynecologist that does the exams, and she provides services to different cities where we currently are. The third important part is how do we decentralize health? So we have a centralized structure that is the hospital, right? That is where people usually go to do more complex exams. And the problem is they are centralized in the largest cities. So with our units, the advanced telehealth units, our key concept here is we make this health accessible, decentralized, distributed, and digitized. This is what you've seen in the video, which basically are, you can move on to the next slide, talking about the solutions. So the unit is the place where we have connections. That is a key thing here. In Brazil, we're getting much better with the infrastructure that we need to do these current exams. We realize we don't need such a high quality internet. The internet that we have is usually enough, except from far distant regions, but patients can still come to our unit and the internet is there so that they can do and perform the exam. So this is sometimes it's a myth. And I think this is important for the work that we are doing. All of us, all organizations and Philips Foundation, sometimes innovations, they don't get adopted at a massive scale because there are some myths around them. One of the myths that we saw is that you don't have the infrastructure you need to make this kind of exams available. But what we've shown is that you actually do. You have some large universities waiting for 5G to make exams possible. Of course, you need that in some sort of exam, but for basic, more accessible exams like the ultrasound, that is not necessary. And what we have is enough to save lives. Because these women that we are attending, they would have no option if we were not there. They would have to travel long distances. A problem in Brazil, that is a big country. They would have to travel more than 100 kilometers to get there. And what impact does that have in their work, in their family life? So this is something that we've learned, that sometimes the myths are not real. And we believe that this model that we developed, the advanced telehealth unit, is important so we can make the access a key component here. And I really admire the work that Philips Foundation and these organizations are doing, because usually when we think about innovation, we have a tendency in most cases to think about how we make products better, how do we make healthcare every time better. So we're using each time more technology to develop each time better products to each time fewer people. So a key component here is that when we have a driving force that is focused on access, I think that we have a shift in a mindset that allows us to think, okay, what kind of new dynamics, new processes, new relationships do we have to build in order to make these innovations accessible, right? So I really believe that this alignment between innovation and access brings a whole new strategy on how we approach our projects, our partnerships, our government. So I'll move on to my last slide, and here's what I would actually change a little bit based on what I've learned here. Harvard has been an amazing opportunity to learn from other amazing projects around the world that are thinking on how can we make our solutions make the world a better place, either in health, either in education, either in finance, energy. And a key takeaway for me here is we should learn how to divide the challenges into two components. First is a technical component, and this plays a huge role here, right? Because yes, you need training You need to train, in our case, we use local nurses. The challenge in Brazil, we don't have midwives that wouldn't be allowed here to use this kind of exam. So we train local nurses. We had to train the doctors because when the doctor said, move the ultrasound up, we didn't know what up was. The nurse didn't know, should I move my hand up or change the angle up? So there was a standardization on the concept, right? Everyone talks the same languages. So this is the technical aspect, and we really believe it's key because if you don't have a technical background and it's not solid, innovations will fail. The key takeaway for me here is we should also look at a more relational aspect. And who are the key stakeholders that are essential for bringing support to the movement that we are trying to do? Because as the other amazing speaker said, it's not just doing that locally, but how do we scale, right? How do we get support? And I think that goes beyond the technical challenge. So partnering with universities would be a key aspect for us to bring the credibility to the project. And also, especially, how do we think about other players like the government, like the doctors' associations, because power shifts. When you provide power to the nurse locally, power shifts, and this is an important component. So I think also as a way, I would add a 4D, not just distribution, decentralization, and digitization, but also how do we do what we are doing? And bringing these partners is essential for that. And education plays a key aspect on that, not only in the technical, but also in the relational aspect. So I appreciate being here with you. It's been amazing and looking forward for the next day.
Thank you so much, Sabine. And it was so interesting just listening to you and getting to relate with some of the challenges that you have. And we have cross-cutting problems or challenges that we face in most underserved communities, regardless of what geographical location they're in. I'm getting now to a very exciting part. Sorry, I can hear a bit of an echo. I'm not too sure where that's coming from. A very exciting part where now we answer answer some of the questions that are coming in from the audience, and also provide some level of clarity where details or more information is being requested for by the audience. And for this panel discussion, I will again remind our participants to kindly share the questions in the chat box so that we are able to address their particular concerns. But to start us off in this conversation, I want to start with you, Prof. Marlene. You mentioned that you worked with WHO and you now work more at a country level. Can you please elaborate how some of the lessons you've learned from the field translate into WHO's official guidelines? How often are these guidelines revisited?
Thank you, Dr. Butoni, for that question. A guideline development at WHO is a long process, tedious process, because first of all, there are technical groups who are providing the evidence, facts and figures from all over the world. Then there are several committees and working groups and workshops where all the areas, all the regions are represented. Experts, not only in the field of obstetrics or but also technical. So everyone who has a role to play is invited to these meetings. And then draft guidelines are produced, they are shared with everyone, input is provided, and then they go through a number of WHO committees, so it's a long process. But back and forth between headquarters, regions, and the Ministry of Health, because WHO actually is the secretariat to all the ministries of health in the world. So everyone is involved. And then, it's what is a guideline from WHO? It's like, I've been a politician as well. I was an elected senator in my country. And it is like a resolution in parliament. It's not legal, it's not binding, but if you have a WHO guideline, then the ministries of health and the countries, they can use this exactly as you use a resolution to kind of make a change in their own country. So what happens is that some countries, some ministries, then they say, look, this is a guideline from WHO. Will we as a government, are we going to implement this? In theory, everyone will say yes. But implementing and scaling up a guideline requires a lot of time, commitment from the government, domestic resources, stakeholders. So it is really the leadership, and we have learned this in the MDGs. What is one of the important lessons from the MDGs, you can really reach your goal if the highest levels in a country, in institutions are involved. Because not only the Ministry of Health, also the Ministry of Finance, everyone has to commit. Then you can really progress.
Thank you so much. Yes,
does that make sense?
Yes, makes sense. You always need policy direction. You always need the key stakeholders putting their voice into that conversation and actually having the right political will to be able to support a lot of the innovations that are coming in to provide access in underserved communities. I'll quickly move on to Sabine as well, just because I'm curious to hear SAS Brazil is pioneering and using telehealth to improve access to care in underserved communities in Brazil. From your experience, how can these technological innovations be leveraged to improve health equity and have equitable access to these resources?
I would definitely agree with what Dr. Marlene said, because
yes.
We believe that there has to be a guideline that focuses on that. Telehealth and teleultrasound wasn't even allowed in Brazil. It wasn't allowed before the pandemic. It was approved as an emergential condition of the pandemic, and it's only been regulated for 4 months now. So it's new, and if we don't have government support, this should be a strategy, and that's what we are looking into. How can we make our work and others' amazing work as a way to give comfort to government and say, this works. This could be part of your public policy strategy. And we're really excited. I think Brazil is in a changing moment. It's the first time we have an area inside of the health ministry that is looking for digital health alone. We really believe these kinds of regulations and guidelines, they are key to bring legitimacy to this kind of initiative. So I think that's the way to go, and bringing others on board. Once you have a success case, it is easier to get others on board, and I think we've done that. So now it's the key, how do we have this partnership built?
Thanks for that, Sabine. And I want to move over to Dr. Nithi, who really was on the ground and training these midwives and just empowering them to be able to conduct this ultrasound, because of course the cadre of practitioners at this lower level facilities might not be the same as you would find in higher level facilities. So Doc, from your experience in Mimba Yangu project, what factors should we consider before implementing such ultrasound programs to scale to novice users who primarily it is not in their scope of practice ordinarily to provide ultrasound services?
Thank you, Dr. Muthoni. I think that's actually a very important question that we should ask ourselves, and it's got a multifaceted sort of an answer. And it's driven in multiple ways, but I think first and foremost, we have to make sure that the people who we are recruiting for projects like these or to be able to provide services like these should be interested, and they should want to be a part of learning something new technology-wise, because it's going to take up a lot more of their time. Like you said, it's not their primary area of work or expertise. So it'll involve having the time and the motivation to learn and then to continue learning and keep improving. The second Part of that would be to consider the health systems themselves and to ask ourselves that if we're able to train these sort of novice users, like you would say, whether they're nurses, whether they're midwives, would they be able to get a chance to utilize their skill? Is their health system equipped with the infrastructure to be able to scan patients? Are patients readily available? Will they be able to come to the facilities? And then, of course, we have to be able to provide some sort of support. So is there that sort of support system in place, whether it's at a local level, through the county themselves, or through the health facility? Is there access to maybe a virtual sort of support system? And I think that's one of the things we learned from our project. It's easy to train someone and do an exam at the end of it and say that, okay, you're trained enough and you're ready to go. But when you're actually in the thick of things and you're doing the scans and you're implementing now the project, so to speak, you find yourself lacking in so many ways. So you should have access to being able to get assistance, because it's not just about you, it's about the client who you're serving. So like I said, multiple things to think of, but I think support becomes very, very important as well.
Yeah. Thank you for that, and makes absolute sense to have the necessary support at all levels to be able to implement a successful program. This question goes to Prof. Marlene. Could you elaborate more on the pregnancy outcome indicators that were measured in the project and how they evolved?
Thank you for that question. I'm sorry. When we developed the protocol, the research protocol, we were hoping and thinking that we could do have as indicators, for example, preterm birth, small for gestational age, stillbirth, maternal mortality. Surely not. It's still too high. But in a project like this, you would not be able to measure actually a difference in maternal death. So doing the sample size and the power calculations, we realized that within the remit, within the limitations of the project, we would not be able to really powerful measure the indicators, the pregnancy outcome indicators that we were hoping to look for. So we discussed with many around the table what are proxy indicators. And as I said already, if we can, by introducing the ultrasound, if we can get women earlier in pregnancy to come to the antenatal clinic, that on itself, on its own, it's already a major improvement of care. So we did that, and indeed, in the areas where we used ultrasound, women came earlier. That means that we had more time to discuss the birth plan. We had more referrals, and as Dr. Needy was giving as an example, like this woman with the triplet pregnancy would never have been referred to a higher level and for safe delivery, etc. So the study did not really empower to look at the individual outcomes. We have them, but the sample is not large enough. But what we can see is indeed proxy indicators such as gestational age and the involvement of the man. We always talk about, pregnancy and delivery are women affairs, but it's so important to have the knowledge, the awareness, and the support by the partner, by the family, and that is really a big, a good indicator and a good result of the study. We hope to do more, and we really hope maybe we can learn a lot also from the presentation from Dr. Boloini, because I think, training, it's great, and then we have a number of centers, but we have to use telemedicine, and maybe have one center and the others where we can communicate and we can supervise so that we have a larger reach with the same number of equipment, same cost. I hope so.
Great, and again, now based on that, I will come back to Sabine. You mentioned the need to manage and resolve relational challenges, not just technical issues. The audience would love to hear more about this. How do you think a company like Philips could help convene the right people and facilitate the right conversations to be able to tackle these challenges?
Yeah, that's a great question. I don't think I have the right answer. But what I feel is that we should, as projects and as partners or as sponsors, think of ourselves as part of an ecosystem that goes far beyond our own and specific role. And I think it is important for everyone that is involved in an initiative or in the corporate side or in the social side, the nonprofits, that's our case, or government, to be able to think of strategies that go beyond the technical, because it is easy to fall in love with the technical challenge. How do we solve that protocol, that referral challenge, that outcome challenge? But I also think that this mindset on what are the projects that we're sponsoring, who's part of the ecosystem, I think this would be a good way for Philips to invite their partners to think about the ecosystem. How can we leverage and bring those on board so that's not our test case in SAS, it's the whole partners that contributed for it to happen. So I think that this mindset shift is important.
Great. And now to Dr. Neethi, I think this really comes because of the field work that was done at Kilifi County. How sensitive is the ultrasound device able to determine the low birth weight, the LGA, and birth defects? If that happened during the study, what was the action that you would provide for the mother?
That's a very, very good question, and a very important one as well, considering that we're talking about ultrasound devices and quality of images. I think well, on the start off, you can't really compare quality of a handheld device to quality of a standalone high-end ultrasound equipment, which you would see in a large radiology setup. That said, within the scope of our study, what we found is that the device that we used, which was of course a Lumify, was a very good device. We were able to give very good quality images, some comparable to what we would have at outreach centers within the country, where we're not using high-end equipment, but mid-range or low-end equipment. Unfortunately, within the scope of our study, we weren't really able to assess low birth weight or small for gestational age, only because our goal was to be able to provide at least one ultrasound to as many women as possible. But we did have a mechanism in place where we explained and taught, and this is where the theoretical classes came into play, where we taught our midwives what are the things that we have to look out for and what constitutes a referral, because they are just a screening measure. And that's what we train them for. We train them to be able to do screening ultrasounds, and then if they pick up anything that would constitute a high-risk case, and I would say that in inverted, in air quotes, high-risk case, whether it's a low-lying placenta, whether it's multiple gestation, we had a referral system in place with support from the county, both at sonographer level and at consultant level. So even though we were not really able to provide direct feedback, we did have that referral in place to be able to provide better services to the patients who were coming in. I hope that answered the question.
It does. And of course, it goes back to what Prof had mentioned earlier, that you must have support at all levels to be able to actually implement something and even be able to scale it up. Again, this ties to another question that's quite similar, but coming to Prof, could you elaborate any pushback or challenges you received from different levels of care when midwives are conducting scans, and how you were able to overcome that?
Thanks, Mutoni. This is not an easy one, because in some parts of the world, the ultrasound is done by doctors or by midwives, like in the Netherlands, in Belgium, etc. But here in Kenya, total ultrasound is done by radiographers and sonographers. And on the other hand, prenatal care and the care of women in childbirth and antenatally is provided by nurses, midwives. So it is actually kind of who has the right or to provide care. We think it should be implemented within prenatal care. So the midwife, the nurse, is actually the one that is closest to the mom, because also she knows pregnant women, she knows how they react, how to communicate, if there is a problem, etc. Having said that, that doesn't mean that radiographers who are doing obstetrical ultrasound, that they can not have this sensitivity. So, but legally, formally now, a midwife is not entitled. In a research project, yes, but as kind of service provisions she can do, but it has to be endorsed, signed off by a sonographer or by a doctor. So we need these regulatory frameworks have to be developed. I think for the future, it should be, both groups should be able to provide the quality of care, but it should be part also of midwifery training.
Thank you so much. And we have so many questions coming in from the audience. I wish we had time to take them all and still have time for last remarks. But I want to take one last question coming in, and really just to see how do you feel, and this is to all the panelists, Dr. Nithi, Prof, and Sabine, how do you feel Philips Foundation is helping in identifying the most in need communities and mobilizing local partners? What level of support do you feel is currently there? Maybe Prof, I can start with you since you're unmuted.
Okay.
Yeah.
Well, thanks. I think we were very happy to form this partnership because Philips provided the equipment, but thanks to the foundation, we could do all the other things. I mean, the thinking, the discussions with the foundation, with all partners involved. What do we really need to have a better quality of care? So we talked about all these elements. I'm not going to repeat them as a partnership. And then we got support to implement research to address some of the questions. And come back to the Philips Foundation colleagues, discuss it together again, talk about the next parts, the next steps to be done. So I hope that Philips Foundation will continue to play that role, and also to now this meeting, for example, I was very interested hearing what is happening in Brazil and thinking, oh, we should work together and maybe, you know, have one of these techniques, or hope that Philips Foundation can help us to partner and maybe to implement what they do in Brazil also in Kenya. So yeah, that is, I'm really happy with that collaboration, the partnership.
Right, and in 30 seconds for each, Dr. Nithi and Sabine.
I think something that was very positive, especially in our case, because we had technology, and technology often faces challenges even when you're in the field. So as much as Prof has already talked about how the foundation has supported us in terms of giving us a platform to think and implement, I really have to say that the technological team gave us a lot of backup and support in terms of just the device itself and optimizing the device as per our requirement. So I think that the team is really great, the local partner is great, and they've helped us achieve what I think Prof set out to kind of see whether we can bring this sort of technology to the underserved within Kenya. So thank you.
Thanks. And Sabine, any closing remarks also from your side?
Yeah, I think what was really interesting and is really interesting in the partnership is that it isn't possible for a global company like Philips to know the specific needs of each community on the ground. So this idea of sharing the technical knowledge, the technologies, the devices, and also being open to listen. This is works. This is what doesn't work. And in innovation, we are always facing things that might not work. And we were really welcomed by the team, the foundation, to also share this knowledge. So I'm really grateful, and I believe that this mindset also really helps addressing the local needs, but also the local knowledge to make innovation work.
Great. Thank you so much. And thank you for the panelists. Thank you to the audience for making the time. I think this was a really interesting conversation. I wish we had more time for it. So challenging the team to probably have a part 2, but these are conversations that can go on and on, but it begs the question, are we making sufficient use of opportunities offered by the technological and digital innovations to improve equity in access to health services? That, I think, is a question which should all be answering. And I have had the honor of moderating this, and listening into the conversations has been extremely interesting. So thank you very much, and do have yourselves a lovely evening. Bye-bye.
Bye-bye. Thank you.
We started screening patients in September 2022. Since we began, we've had a positive turnout, and we are able to diagnose.
You'll pick your first electrode and place it right there.
Cardiovascular diseases, currently they're adding up to the list of the other diseases we have in the country. If we don't put measures in place, then it's going to become #1 killer